Hello, welcome to MRA's presentation of Behavioral Health Coding and Diagnosis Review. My name is Jennifer Jones, and I'll be your presenter today. Some of the objectives of our presentation today include going over Chapter 5 Official Coding Guidelines, reviewing the hierarchy for code selection, reviewing some ICD-10-CM coding diagnoses from the Chapter 5 section, reviewing the importance of documentation and code selection, and reviewing current coding clinics in relation to Chapter 5 diagnosis. Before we get started, let's just go over a few of the basics. This includes the hierarchy. This is something that is sometimes forgotten, and there is a hierarchy to coding. It starts out with the conventions. This is in section 1A of your book. The conventions include the alphabetical index and tabular, your abbreviations, that includes the NECs and NOSs, punctuation, brackets, parentheses, and colons all fall under punctuation. Your ands, other and unspecifieds, your instructions on inclusions, includes, excludes, and those pesky excludes one and excludes twos. Etiology and manifestations, what to code first, or what code first means, those notations for use additional codes, and in diseases classified elsewhere. Again, your ands, your withs, your C alsos, your code alsos, defaults, code assignment, and clinical criteria. Those all fall under the conventions. So as a coder, doesn't matter how long you've been coding, you need to make sure that you understand the conventions, and it's always good to refer back to the book or to the online version of the conventions for more information. But conventions are at the top of the hierarchy, so that's what you go to first when you're trying to figure out a code selection. After that, we get to the official coding guidelines. That includes your general coding guidelines, your signs and symptoms, diagnoses that are integral part of a disease process, your alphabetical index, and your tabular. So again, this is the second rung on the ladder, the second rung from the top on the ladder, the official coding guidelines. That follows the conventions. And then we have the coding guidelines in Chapter 5. There's not very many, so I'm just going to go over them now instead of going over them later, since we're going off of the hierarchy and the ladder of hierarchy. So the first coding guideline is 5A. It's pain disorders related to psychological factors. B is mental and behavioral disorders due to psychoactive substance use, talks about in remission, your psychoactive substance use, abuse, and dependence, psychoactive substance use unspecified, medical conditions due to psychoactive substance use, abuse, and dependence, and then blood alcohol level. So those are all in the coding guidelines. Then there's the factitious disorder, that's 5C, also known as Munchausen syndrome. And the coding guideline basically says that factitious disorder on self or Munchausen syndrome codes to F68.1 with the 5th character. And then also code a T code for abuse. And a new guideline to Chapter 5 as of October 2023 is 5D, and that's regarding dementia. What this guideline says is that dementia is classified on the basis of etiology and severity. So that would be unspecified, mild, moderate, or severe. And if provider documentation does not indicate the severity level, code to unspecified. This would be a good opportunity for provider education regarding documentation, to let them know that if they are able to determine a etiology and severity, to please document that, so that we do not have to default to the unspecified code. Okay, so conventions are first, then we have the coding guidelines, and the third rung from the top on the hierarchical ladder is the HA Coding Clinic. Then at the bottom of the ladder are other references, for example, the Coding Handbook. So again, this information is not specific to just Chapter 5, mental health disorders, but for all aspects of coding, the hierarchy is something that is sometimes ignored or forgotten. So we just wanted to review that and go over it as a reminder or a refresher. So always follow your conventions first, then your coding guidelines, then comes your coding clinic, and then other references. Okay, now let's get going into diagnoses and documentation for Chapter 5. This chapter is titled Mental, Behavioral, and Developmental Disorders. The first set of codes in Chapter 5 are your FO1 to FO9 codes, and these are mental disorders due to known physiologic conditions. This includes mental disorders with an etiology in cerebral disease, brain injury, or other insult that leads to cerebral dysfunction. The cerebral dysfunction can be either primary or secondary. Primary includes diseases, injuries, and insults that directly and selectively affect specific parts of the brain. Secondary includes systemic diseases and disorders. Disorders that fall into this secondary category include dementia, which can be vascular, in diseases classified elsewhere or unspecified. There could also be conditions due to known physiologic conditions. Make sure that you code the underlying physiologic condition with an exception for FO3. So for FO1, you code first the underlying physiologic condition or sequela of cerebrovascular disease. So make sure you follow the instructional notes, again, which say to code first that underlying physiologic condition with the exception of FO3. This is a newer coding clinic, which is a good example of coding first the physiologic condition. It's from 2022, page 25 of first quarter. Alcohol abuse with alcoholic dementia codes to F10188, alcohol abuse with other alcohol-induced disorder, and FO2.80, dementia and other diseases classified elsewhere without behavioral disturbance for alcoholic dementia. So again, make sure you're reading those notes. Code first the underlying physiologic condition, which is the alcohol abuse. And that's going to be your F10188 first. And we also have an older coding clinic, which is also a good example of coding the underlying physiologic condition. This is for Parkinson's dementia. The coding clinic states Parkinson's dementia codes to G20, Parkinson's disease, and FO2.8X, dementia and other diseases classified elsewhere with behavioral disturbance. So again, this is a code first, the underlying physiologic condition, which is the Parkinson's, and that will be your primary diagnosis. Another good example is Alzheimer's disease. This coding clinic says Alzheimer's disease codes to G30.9, but dementia is an inherent part of Alzheimer's. So code in addition, F02.8X, dementia and other diseases classified elsewhere with or without behavioral disturbance. So again, code first the underlying physiologic condition, which is the Alzheimer's. And this is going back to your coding conventions for your code firsts. This is a clarification. A major neurocognitive disorder without behavioral disturbance codes to F03.90 when the underlying condition is not known or not further specified. So again, there is no index entry for disorder, neurocognitive major without behavioral disturbance. So there's only a code for with. So when you have the diagnosis of major neurocognitive disorder without behavioral disturbance, you're going to code to the F03.90. So make sure you're paying attention and not just going with behavioral disturbance. Pay very close attention when you're going through the index to compare your documentation to the code selection. And even though major neurocognitive disorder without behavioral disturbance is an inclusion term under the Code for Vascular Dementia, which is FO 150, when the appropriate or when the underlying etiology is not known, then use the Code for Vascular Dementia. Using the Code for Vascular Dementia is inappropriate. And that is from a coding clinic, second quarter 2021, page 4. So that these last two slides are a couple of good slides to remember, and just go back and maybe double check that coding clinic and look at your index and understand what that is referencing. Also includes conditions due to known physiologic conditions, FO4 to FO9. This includes amnesia, delirium, other mental disorders, personality and behavioral disorders, and unspecified mental disorders. And again, there is a code for the underlying physiologic condition with these codes as well. If a disorder is noted to be due to a physiologic condition, refer to the index and code appropriately. So there is an index entry for bipolar due to a condition. It tells you to use FO 6.3, and then anxiety due to FO 6.4. So again, make sure that you understand your due tos. Don't always go by your encoder. Maybe have a copy of the electronic index up, or your book, and kind of pay attention to those. You don't want to be misled by an encoder, but there are some codes that have the due to. All right, next are the post-traumatic organic brain syndrome. That goes to FO 7.81. This is your post-concussion syndrome. There is a note to add a code for any associated post-trauma. So if you have that post-concussion syndrome, you would code the FO7 along with any traumatic injuries that happened with that. FO9 represents your organic brain syndrome. That's including decreased mental function due to disorders or diseases other than psychiatric. So that's going to be your dementia, your agitation, and your confusion. All right, next we have mental and behavioral disorders due to psychoactive substance use, which fall into the F10 to F19 categories. These are going to be due to substance use. This is one of the hardest concepts for coders to learn. It is imperative that coders know the coding guidelines regarding use, abuse, and dependence, and also when to use in remission codes. So use, abuse, and dependence are different, assigned different codes in ICD-10. Again, it's very important to know what the different terms mean and know the hierarchy for reporting. Substance abuse and dependence are classified as mental disorders, and that's why they are in the Chapter 5 section. So let's go through the definitions first of use, abuse, and dependence. First of all, use is low frequency. Irregular use could be known as experimentation of alcohol or illicit drugs. Abuse is problematic use of drugs or alcohol, but without dependence. The recurring use of alcoholic beverages or drugs despite negative consequences. And then dependence is increased tolerance to drugs or alcohol with a compulsion to continue taking the substance despite the cost. Withdrawal symptoms often occur upon cessation in the presence of symptoms such as tolerance and withdrawal. So again, 3 different codes, 3 different uses: use, abuse, or dependence. You need to know the difference between all 3 of those. And then we have the hierarchy, and this is in the coding guideline. There is a well-defined hierarchy which needs to be followed. Only one code can be used, and you have to refer to that hierarchy for correct code reporting. So here is the hierarchy. We have substance use, abuse, and dependence. If both use and abuse are documented, you're only going to assign the code for abuse. If both abuse and dependence are documented, you're only going to assign the code for dependence. If use, abuse, and dependence are all documented, assign only the code for dependence. And then if both use and dependence are documented, only assign the code for dependence. So of course you can see the hierarchy is that use is at the bottom of the ladder. And then we have abuse, which is a little more severe. And then dependence is the most severe. So when you've got multiple different types of documentation on the use, abuse, or dependence, you're always going to go with the most severe, dependence being the most severe. And there were some changes to the official coding guidelines for assigning use. This was a change in 2022, but it was so effective last October of last year, but it's still a change that needs to be reviewed for 2023. This is very important and often forgotten by coders who just look at the documentation, but refer to the hierarchy, who sometimes just refer to the hierarchy and then just code to the alcohol or drug use. So use codes should only be assigned, of course, based on provider documentation when it meets the definition of a reportable diagnosis. And then this is the most important instruction that is often overlooked, and it is in this coding guideline here, only when the psychoactive substance use is associated with a physical, mental, or behavioral disorder, and such a relationship is documented by the provider. So the key here is that it has to be, the use has to be associated with a physical, mental, or behavioral disorder, and that relationship must be documented by the provider. It cannot be assumed. So again, make sure that you understand this particular guideline, anything that's regarding psychoactive substance use. Again, it has to be associated to code use. It has to be associated to a medical condition, a behavioral disorder, or a mental disorder, and that relationship has to be linked. For alcohol and drug abuse, if the severity is documented to be mild, is equivalent to coding to abuse. For alcohol and drug dependence, if the severity is documented to be moderate or severe, that's going to code to dependence. So again, severe codes to dependence, mild severity codes to abuse. So if that severity is all that's documented, you're mild, moderate, or severe, you're going to follow the instructions and code to abuse or dependence. So mild or moderate, mild codes to abuse, and moderate or severe codes to dependence. Regarding alcohol use disorders, if that is what is documented and there is no further specificity, there is not a code to assign. We have to query the provider for the severity to try to get that mild, moderate, or severe, or the abuse or dependence. There is no default code for disorder, alcohol use, unspecified in the index. If alcohol use is documented without the term disorder, there is an index entry for use, alcohol, and that's Z7289. So make sure that you understand also that this index entry does not fall into the F codes that are listed in the use guideline, which are the F codes. So again, it's paying attention to the documentation and the words. Alcohol use disorder is not indexable without a severity. So if they just say alcohol use, then you can use that Z7289 code according to the index. It's not going to fall under the guideline for the F codes for alcohol use because there is an entry in the index for alcohol use. And again, this is going back to following the hierarchy of coding. You use your coding conventions first, which says, basically you use your tabular unit index. and then you go to your guidelines, and then you go to your coding clinics and your other references. So and that's why I kind of put that in there at the beginning of this presentation. We have to remember the hierarchy. If drug use disorder is documented, the key word here is disorder, and there is no specificity documented. There is not a default code for unspecified, and again, a query would need to be initiated. Unlike the alcohol use disorder unspecified, or alcohol use unspecified on the previous slide, which gives us a Z code to use, there is not one for drug use. So again, drug use disorder, you would index the word disorder and then go to your drug, but you're not able to assign a code without a severity, mild, moderate, severe. So again, this is an opportunity for provider education. Let them know that if they're going to use drug use disorder as a diagnosis, they need to provide the severity, mild, moderate, or severe. If documentation is of an alcohol or drug-related or induced disorder, and there's a link between the disorder and the alcohol or drug, you follow the index. If you index disorder and then you choose alcohol or a specific drug, and there's a with to go along with that, assign the code from the index that is associated with the with. So again, back to the coding conventions. If a drug-related disorder is the only documentation without a specific disorder linked, we recommend that you query the provider to clarify what the associated disorder is and the specific drug and severity of use if it's not identified. There is that F19.99, which is basically unspecified. But if the documentation states that the provider is unable to determine the specific associated disorder, code to unspecified disorder with drug use, abuse, or dependence, depending on the severity. So there is a code, but because we have more specifics, and the purpose of ICD-10 is to be as specific as possible and not use unspecified codes, we would recommend querying the provider to see if you can get that link and the severity if not provided. There are a couple of new coding clinics. The first one addresses alcohol abuse with anxiety. It says, if alcohol abuse with anxiety is documented, do not assume a relationship between the alcohol abuse and the anxiety. So this again is with the word with. Even though there is an entry in the index that links alcohol with anxiety, alcohol-induced anxiety disorder is not the same as having anxiety and alcohol use, abuse, or dependence. So the tabular narrative indicates that codes in category F1018X are assigned for alcohol-induced disorders. So Coding Clinic says the provider must document the relationship between and develop a link between the two conditions. Do not assume a relationship between substance abuse and dependence and anxiety, a mood disorder, sleep disorder, or sexual dysfunction. So this is a super good coding clinic to remember. And again, it is newer, first part of this year. So you cannot assume a relationship between substance abuse and dependence and an anxiety, a mood disorder, a sleep disorder, or sexual dysfunction. The provider has to develop the link. So just using the word with isn't going to be good enough. Another newer coding clinic, it says, do not assume a relationship between a substance abuse and dependence disorder and anxiety, mood disorder, sleep disorder, or sexual dysfunction. Again, pretty much the same thing that we just went over. Also in Chapter 5 are your tobacco and nicotine codes. There are always questions regarding coding different ways, ways to code tobacco and nicotine, use, abuse, dependence, smoker, and then the different types of products that are used. So per the index, smoker, so if all you have is a documentation of the patient is a smoker. If you index smoker, it does tell you to see dependence and then drug and then nicotine. There are different types of products. We've got one for chewing tobacco, one for cigarettes, one for a specified product, and then there's also a drug dependence with disorder. From there, you can go into in remission with a specified disorder, NEC, or in withdrawal. So lots of information can be taken from one specific statement regarding how a patient smokes or how they use their nicotine. History of nicotine dependence is classified differently than other types of drug dependence because there is a unique code for history of nicotine dependence. So this is an exception to drug dependence, as a history of drug dependence is classified by type of drug in remission. And that is from a coding clinic of 2017. So there is a code for history of tobacco dependence, which is Z87.891. Here are some scenarios regarding tobacco and nicotine. If a patient smokes 3 packs of cigarettes per week, that would code to F17.210, smoke cigarettes. Electronic cigarettes codes to F17.290. She is a smoker, that would code to your F17.2, and then you just have to specify what's being smoked. His tobacco use has been reduced. You can use a Z72.0 there. The patient abuses tobacco products, also Z72.0. And if you index tobacco abuse, it actually tells you to see tobacco use. So again, coding conventions, coding guidelines. Make sure you know this coding clinic from 2017. It gives you some good scenarios. Now, there is a guideline regarding remission, and documentation needs to be clear that the patient is in remission. To be able to code in remission from a psychoactive substance, it requires the provider's clinical judgment and documentation of remission. Can't just because the provider says, oh, they're cutting back or they haven't smoked in 3 months, that's not good enough documentation. They have to say that they are in remission from the psychoactive substance use. And that's not just for alcohol or tobacco, or it's for all. So remission has to be documented by the provider. The description under the in remission codes includes in early remission, sustained remission, and sustained remission. However, there is not a description of partial remission. So that one is, if you see documentation of partial remission, there is no code for partial remission. If that's the only documentation you have, then the condition is going to code to the dependence or the abuse, depending on what your documentation shows. So you're going to refer to the tabular description under the code for alcohol or a specific drug dependence or abuse. And again, it only includes early or sustained remission. And this documentation has to come from the provider. It cannot come from nursing or other documentation. Clearly must be based on provider judgment and documentation only. However, if the index entry leads you to an in remission code, you can use remission. And this will be shown on the next slide. But again, you have to go by your coding conventions and guidelines. So if there is an index entry that leads you to an in remission code, you are able to use that. So here we have documentation of mild substance use disorder in remission. This codes to abuse. If documentation is of moderate or severe in remission, codes to dependence in remission. So early or sustained remission. This can be mild substance use disorders in early or sustained remission, codes to substance abuse in remission, and moderate or severe codes to substance dependence in remission. So make sure you're paying attention to your guidelines regarding in remission. Now, what about your history ofs? For documentation of history of alcohol or drug use or dependence, refer to the index and follow where this leads. The index entry for history of alcohol or drug dependence tells you to see dependence drug by type in remission. So read your coding clinics and follow the index for your history ofs. History of alcohol or drug abuse codes to Z87.898, personal history of other specified condition. There is no index entry for history of drug or alcohol abuse that says to see in remission. So only code to in remission based on the provider documentation unless otherwise instructed by the classification. So again, there's no index entry for alcohol or drug abuse that says to see in remission. So you can only go off the provider documentation. So you can see why drug abuse, abuse, and dependence, including in remission, is often a tough topic to understand. Unless you're working with these types of diagnoses often, you may have to refer to your resources before coding these diagnoses. So again, hierarchy, check your conventions, your coding guidelines, your coding clinics, and your coding handbook, and always use a reference book. Look up the codes in the index if you have any question. Make sure you read the entire code description. Pay attention to your code first, your excludes, etc., and make sure that you're coding these conditions correctly. I think, honestly, that some of the codes that fall under the Chapter 5 codes are the hardest to understand, even though they should be simple. There's just extra thinking that has to go into knowing the hierarchy of the use, abuse, and dependence, and knowing when you can code in remission and when you can go to the book and follow the index versus provider documentation and the history ofs. Next in the Chapter 5 book are codes F20 to F29. These represent schizophrenia, schizotypal, delusional, and other non-mood psychotic disorders. These are also often difficult to code as different terminology is used to represent these codes between F20 and F29. There are many types of schizophrenia, which is a severe mental illness. Some of the symptoms of schizophrenia include social withdrawal, loss of contact with reality, decreased emotional response, speech disorganization, thinking disorganization, and bizarre behaviors. There are different types of schizophrenia, which include paranoid, disorganized, catatonic, undifferentiated, residual, and other types, which includes schizophreniform disorder and other schizophrenia. And then there's an unspecified code as well. Oftentimes, if the only diagnosis given is schizophrenia, a query should be initiated to try and determine the specificity if known. Coding Clinic from 2019 says chronic schizophrenia with an acute exacerbation codes to F20.9 schizophrenia unspecified. There is no differentiation with severity or exacerbation. It's kind of funny. There are so many codes in the code book and some that are very specific, with the exacerbation. And to me, schizophrenia is a pretty severe mental disorder. So you would think that there would be a code for an acute exacerbation, but there is not. It just goes to schizophrenia unspecified. Two other disorders in this code range, the F20 to F29 includes other specified schizophrenia spectrum and other psychotic disorder. So that's one code, and unspecified schizophrenia spectrum and other psychotic disorder. So that's your V28 and your F28 and your F29. The only difference in the two code descriptions is whether or not the documentation is of other specified schizophrenia spectrum or unspecified schizophrenia spectrum disorder. So make sure you watch your documentation. These two simple words can change the diagnosis code. So according to DSM-5, and we don't code according to DSM-5, but it is one of those other references when you're coding mental, behavioral, and neurodevelopmental disorders. That's a great reference. The F28 and F29, this category applies to presentations in which symptoms characteristic of a schizophrenia spectrum and other psychotic disorder that cause clinically significant distress or impairment in social, occupational, or other important areas of functioning predominate but do not meet the full criteria for any of the disorders in the schizophrenia spectrum and other psychotic disorders class. So just a little more information from DSM-5. Again, a great reference if you are someone that codes a lot of behavioral disorders is to have that DSM-5. Even though we don't code according to it, it is a great reference for definitions of the different disorders. The other specified schizophrenia spectrum and other psychotic disorder is used in situations when the clinician chooses to communicate the specific reason that the presentation does not meet the criteria for any specific schizophrenia spectrum and other psychotic disorder. So that's done by using the diagnosis other specified schizophrenia spectrum and other psychotic disorder, followed by the specific reason, like a persistent auditory hallucination is often common with this. Some examples that can be specified for using that other specified designation are the persistent auditory hallucinations, delusions with significant overlapping mood episodes, attenuated psychosis syndrome, or delusional symptoms in a partner of an individual with a delusional disorder. Now, for your unspecified schizophrenia spectrum and other disorder, per DSM-5, this applies to presentations in which symptoms characteristic of a schizophrenia spectrum and other psychotic disorder cause clinically significant distress or impairment in social, occupational, or other important areas of functioning, predominant but does not meet the full criteria for any of the disorders in the schizophrenia spectrum and other psychotic disorders diagnostic class. So again, just a little more information from DSM-5 on the unspecified schizophrenia spectrum and other disorder. The unspecified spectrum disorder is used in situations in which the clinician chooses not to specify the reason that the criteria are not met for a specific schizophrenia disorder, and includes presentations in which there is insufficient information to make a more specific diagnosis. So, patient comes into the emergency room. Most of the time, the emergency provider is not going to be able to go into detail and drill down and find out what type of schizophrenia spectrum or what kind of diagnosis that the patient has. So if you index disorder and then schizophrenia spectrum and other psychotic disorder, it codes to F29, which has an ICD-10 description of unspecified psychosis not due to a substance of known physiologic condition. So sometimes you have to just go with those unspecified codes. Depends on your scenario. So again, when you're coding these specified schizophrenia spectrum and other psychotic disorders, whether you go with the other, which is the F28, or the F29 code for the unspecified, depends on your documentation. Make sure your code matches your provider documentation. Is it other or is it unspecified? Your code selection needs to match the documentation for sure. Next in the Chapter 5 codes are your F30 to F39s. Those are your mood or affective disorders. These disorders can be mild, but can also be severe and even life-threatening. They can have further definition by episodes, recurrences, and possibly even the severity, like mild, moderate, severe, without psychotic features or with psychotic features, could be in remission, etc. Some of these affective disorders or mood disorders include major depressive disorder, bipolar disorder, and mood disturbances. Included in these disorders is bipolar, and these can also be noted to be mania, depression, cyclothymia, straight bipolar, or with mood disturbance. So some different types of bipolar. Your severity could be hypomanic, manic, depressed, mixed, or with psychotic features. So this is another instance when query for specificity of bipolar could be initiated. The severity, the type of episode, and if psychotic features are involved, as well as whether it's in remission or not. And also the most recent episode, the type of the most recent episode, all can be clarified depending on your scenario, of course, and your provider. All of these different topics or specificities are great education for providers, and again, a good query opportunity. Let them know that when we have bipolar, that there are many other choices, that if they can document those, if known, that would be great. We can get a more specific and better code. Coding Clinic of 2020 talks about bipolar disorder and major depressive disorders. They both have excludes one notes. And according to Coding Clinic, bipolar includes depression and mania. And so you would not report depression separately. So if you have bipolar as a diagnosis and your major depressive disorder, you're only going to code the bipolar, because depression is included in the diagnosis of bipolar. Another Coding Clinic from 2021 gives a little more information on depression. The previous default was F32.9, but now we have a new code, which is F32.8, depression unspecified. So no longer does just the diagnosis of depression go to major depressive disorder, single episode unspecified. We always thought that was kind of not funny, but an unspecified code going to such a specific description seemed a little awkward. So now we do have that unspecified depression code. Again, we have depression and anxiety, or depression with anxiety. The clear link between the diagnosis of depression and anxiety must be made by the provider. This is one of those withs, ands, situations. So with a clear link, of depression with anxiety is going to go to F41.8, and then anxious depression F41.8 as well. Again, a clear link between the diagnosis of depression and anxiety has to be made by the provider in order to use these codes. So without a link between depression and anxiety, you have your F32A for just depression and then anxiety. So two separate codes. All right, next we have the F40 to F48 codes. These represent your non-psychotic mental disorders. These are going to include things like anxiety, stress-related conditions, somatoform disorders, and conversion disorders. Also, your phobic anxieties and OCD falls in the F40 to F48. These include reaction to severe stress and adjustment disorders, dissociative and conversion disorders, and other non-psychological mental disorders as well. There is a coding clinic which talks about how to code adjustment disorder with depressed mood, F43.21. Complicated bereavement would go to F43.21. But if all they say is the diagnosis of bereavement, you would use Z63.4. So again, make sure that you're paying attention to the documentation. If complicated bereavement is documented, or something that would be a complication of the bereavement, it would code to adjustment disorder with depressed mood. F44.5, conversion disorder with seizures or convulsions, are going to be it's going to be the description for your non-epileptic attacks and your psychogenic seizures. So again, they're non-medical, so they're going to fall into the F codes. Somatoform disorders are your F45s. These are mental disorders with physical symptoms that resemble an injury or a physical disease. There is no identified cause. They are usually caused by mental factors. These are usually patients that have a high level of anxiety about their health, and they have a disproportionate or persistent thoughts about their symptoms, about their health, about being a very worried person. This can sometimes lead to psychogenic diarrhea, hypochondriasis, or illness and an anxiety disorder. Pain falls into this category if the documentation attributes the pain to the psychological component. Again, this is assigned according to provider documentation. We do not assume a link between the term somatic and a psychological component unless the provider specifies this in the documentation. So again, provider documentation is key. There might need to be a little bit of education going on to avoid some queries. Depends on the scenario again. Okay, moving on, we have F50 to F59. These are your behavioral syndromes associated with physiological disturbances and physical factors. These include your eating disorders, sleep disorders that are not due to a substance or a known physiological disorder, and sexual dysfunction. F50 to F59 are not used if the condition can be assigned to a mental disorder classified elsewhere. So pay attention to your index and the documentation. This is where the psychogenic conditions in origin will be coded, is the F50 to F59. We also have mental and behavioral disorders associated with the purpurium in this section. Psychological and behavioral factors associated with disorders or diseases classified elsewhere. This is where your abuse of non-psychotic substance codes will fall, and your unspecified behavior syndrome. F60 to F69 are going to be disorders of adult personality and behavior. This is going to include specific personality disorders, impulse disorders, gender identity disorders, other sexual disorders, other disorders of adult personality and behavior, and then your unspecified disorders of adult personality and behavior. F68, and there's the coding guideline. Again, don't forget to be familiar with regarding the factitious disorder. If it's imposed on self, which is the Munchausen syndrome, it's F68.1. If it's imposed on another, that codes to F68.8. F68.A, and that is your Munchausen syndrome by proxy. So that's the one where it's being manifested on someone else. And then you're also going to add your T codes for adult and child abuse, neglect, or other maltreatment, whether it's confirmed or suspected. T74 is the confirmed, the T76 is the suspected. And there is a coding clinic regarding this, fourth quarter 2018. And again, don't forget that coding guideline. All right, F70 to F79 is going to be where you will find your intellectual disability codes. These would include your mild intellectual disabilities, moderate or severe, profound intellectual disability, other intellectual disability, or unspecified. So again, if you're working with these kind of diagnoses quite often, just maybe do a little provider education and ask for the specificity so that you can get the best code rather than going with that unspecified. There is a note to code first any associated physical or developmental disorder with these codes, and it does exclude borderline intellectual functioning, and that's with the IQ above 70 to 80 to 84. So make sure you're watching your excludes as well, and your code firsts. There are some newer codes created in the last year or so. There's the SYNGAP1 related intellectual disability. That's F78.A1, and that's where there's an insufficient gene. And then F78.A9 is other genetic related intellectual disability. And that code can be used when other specific details are documented, but there's no specific code available. So I haven't really seen that documented much much yet. So maybe that's going to be a newer thing coming up, or maybe children's hospitals, specialty hospitals might have these use for these new codes. Getting towards the end of the chapter, we have F80 to F89 codes. These are pervasive and specific developmental disorders. This is going to include disorders of speech and language. That could be your LISP, speech sound disorders, expressive language disorders, and communication disorders. There are specific developmental disorders of scholastic skill codes and specific developmental disorders of motor function. All fall within the F80 to F89 range. Pervasive development disorders are other disorders of psychological development and unspecified disorder of psychological development. So those are considered pervasive developmental disorders. Your F90 to F98 codes are behavioral and emotional disorders with onset usually occurring in childhood and adolescence. And these codes can be used regardless of age. So even though it says occurring in childhood and adolescence, you can still use them in adults. Generally, the onset is within childhood or adolescence, but they might continue or be diagnosed through adulthood. This is going to be where you find your ADHD codes, your conduct disorders, and your emotional disorders with onset specific to childhood. So again, even though the description says behavioral and emotional disorders usually occurring in childhood and adolescence, usually, regardless of age, you can still use these codes, F90 to F98. Also, some of these codes in this area include disorders of social functioning with onset specific to childhood and adolescence. That could be a tic disorder or other behavioral and emotional disorders with onset usually occurring in childhood and adolescence. So usually starts in childhood, adolescence, can also be diagnosed as an adult, but can be used and applied to patients of any age. And then we have our good old just F99 unspecified mental disorder. That's just going to include a mental illness, not otherwise specified. We try to stay away from that code, of course, as with any unspecified codes, but sometimes it's inevitable. And you will use an F99 code if that's all the documentation that you have. It's an unspecified mental disorder. Well, that is it for the Chapter 5 codes. For mental, behavioral, and neurodevelopmental disorders. Don't forget to review your hierarchy for coding conventions first, coding guidelines second, coding clinic third, and other references, which could be the coding handbook and or the DSM-5 is a great reference book when you are working in Chapter 5. There's always opportunity within the Chapter 5 codes for provider education and documentation improvement in order to get more specific diagnosis codes and your severities. So work with your providers, work with your CDI team if you have one, and try to get a little better documentation if possible. And a list of references are included here in this last slide. Thank you so much for joining today, and until next time.